A little bit of review before we get into and finish the rest of chapter 11. I just want to kind of get a sense for, or for you to get a sense for what you already know in the 2 weeks that you've been in class, just to kind of see what you remember and hopefully see that you're making progress towards knowing a lot more than what you probably think you do. So with this question, it is asking, let me go back. What are the 3 dentition periods? I'll give you just a few minutes to think about this. The 3 dentition periods we have. If you are thinking primary, which is this one on the left, mixed dentition in the middle, and permanent on the right, then you are correct. At what age does mixed dentition begin? And I want you to look at this x-ray here to try to determine that. If you are thinking 6 years of age for mixed dentition, you are correct. If you notice here, we see the first and second primary molars here, and underneath you see the permanent premolars getting ready to erupt into place. And then here you have, behind those, you have what would be the first permanent molar, which if you remember the sequence, we get our first permanent molar at the age of 6, our second permanent molar at the age of 12, and then our third molar typically around the age of 18. So if you can remember 6, 12, 18 for first, second, and third molars, then you are in good shape and know when mixed dentition begins. What teeth do we have in permanent dentition that we don't have in primary dentition? If you are thinking premolars, that is correct. If you remember, there are no premolars in the primary dentition, which is right here. We have 20, going back, 20 primary teeth, 32 permanent teeth. We lose a central, gain a central, lose a lateral, gain a lateral, lose a canine, gain a canine, lose a first primary molar, gain a first premolar, lose a second primary molar, and gain a second premolar. So no premolars in primary dentition. How many tooth numbering systems are there and what are they? If you said 3, that is correct. We have the ISO, the Palmer notation, and the most common one and the one that we use, which is the universal numbering system, where we start with 1 on the upper right, end with 16 on the upper left, start with 17 on the lower left, and end with 32 on the lower right. If you are going to be working in ortho, then you might be using a combination of the universal and the Palmer notation. So you still need to be familiar with the universal numbering system. How many surfaces does the posterior teeth have? And what about the anterior teeth? If you said 5, that is correct. So if this is the mesial, this is the midline, this is away from the midline, this is the cheek, this is the tongue side, and we know this because we can see saliva building up right here. These are premolars, and we know that based on the size and shape of them in comparison. So we know that the premolars come before the molars, so they're more towards the midline. This is our mesial surface here, our distal surface, our buccal surface, lingual surface, and then our chewing surface, which is occlusal on posterior teeth. On anterior teeth, the midline is between the centrals. We have our mesial surface, our distal surface, our facial surface, which is towards the lip, and our biting surface here, not a chewing surface, are considered our incisal, and the surface we're not able to see is the lingual and or palatal. However, just know that lingual is probably going to be used more commonly even when we're talking about maxillary teeth, to identify the surface that's inside the mouth. Now we're going to move on to some anatomical features of the teeth, and it's important to know that the anatomical features help to maintain their position within the mouth and the arch, and also to protect the tissue during mastication. Mastication is a term that you'll need to be familiar with, and know that anytime you hear the word mastication, it's referring to chewing. We're going to be focusing on contours, contacts, height of contact, and embrasures. So focusing now on contours. Contours, when it comes to contours, it's either going to be convexed or concaved, depending on what it is that we're referring to or talking about. And like mentioned, it's there to protect the tissue, to ensure that the tissue will remain healthy. And if a tooth is under-contoured, then that could lead to some issues with tissue trauma or gingival trauma. If the tooth is over-contoured, that can lead to areas where plaque can build up and food can get stuck underneath there. And over time, what it does is it creates decay or cavities, and it's going to cause irritation to the gum tissue, so gingivitis. The teeth are going, or the gum tissue is going to become swollen and red and irritated. This picture here on the left is showing what a normal contoured tooth should look like. What it does is the contouring of the teeth. Again, our teeth are not just square. There is some bulges to them and some contouring to them, some concavities to them. This would be more, if you think of a cave is something you go into, so this would be more of a concavity or a concave. This is going to be more convex. So a concavity is more like something that's concaved is going to be like a bowl where you can put something in it. Convex is going to be the opposite. So the way the teeth are contoured, whether it's anterior or posterior teeth, it allows for that deflection of the food to go and move away from the gum tissue, so it's not going to cause that trauma or irritation. The one in the middle is an example of an under-contoured tooth, and what's happening is the bulges or the convexity and concavity of the tooth is very limited, so it's going to allow for the food to cause some trauma to the gum tissue. The one on the right is an example of over-contouring, meaning that it's over-contour, the bulges, it's bulging out too much. Yes, it's deflecting the food. However, it can create these spaces like you can see under here, which can allow for food particles to get stuck up underneath there. It's going to make it harder to clean the area, and it's going to, if that food and debris stays on there, what's going to happen is that it turns into plaque, and if it's not removed, it can turn into calculus, and calculus is something that cannot be removed. It's going to take you or the patient to go to the dentist to have it either hand scaled off with special instruments, or the ultrasonic scaler to be used in order to break apart that hardened plaque that's developed on there as a result of just the ability to not be able to remove it because it gets stuck up underneath there. So when it comes to anatomical features, it's very important when the dentist is placing a filling, or if that's something that you are going to be tasked with doing, that is a capability of us as assistants. If we get additional training to be able to place fillings, well, we have to understand the anatomy of the teeth to be able to put back the structures that were removed, either because they were broken or because there was decay or cavity there that needed to be removed. So it's our responsibility to make sure that we're putting back what was taken out to ensure that it's going to serve the purpose and function of the contouring to deflect so that it doesn't cause trauma or irritation to the tissue like these two here would do. The next one is going to be focusing on contacts and embrasures. And with this one, contacts are basically where two adjacent teeth come together or touch. And this is important for a lot of different reasons as well, same as we talked about before. It protects the tissue, and we want that contact to be there in between the teeth. When we're flossing, we want there to be a little bit of an effort that needs to be put into getting the floss down so that we can remove any debris or anything that's in between the teeth. So we don't want it just to slide very easily through there. We want there to be a little bit of effort to pop through before we get to removing by the gum tissue. The contacts are important again when we are putting a filling back in, especially if the decay involves an interproximal surface. Interproximal is referring to in between the teeth, because we want to make sure that when we put the filling back in, that we create that contact and have those teeth touching. Usually, and you'll probably see this either with yourself or as you're working as a dental assistant, after a filling is placed, if it's involved the interproximal surfaces, whether it's anterior or posterior, the dentist will always go back and run floss through there to ensure that that contact is going to be tight enough so that food doesn't get stuck in there. Because if there's an open contact, it's going to allow food to easily get stuck in there. I know it's a pain in the butt because I have a couple of teeth that are exactly like that. And I'm always having to carry floss with me, especially with certain types of food, because it's hard to get out of there and it just gets stuck in there. So it is definitely irritating and to the patient. So we want to make sure that that contact is put back in. And there's just some times that we just can't help it. There are just the way the teeth develop. Maybe it's abnormally small teeth and abnormally large jaw, which are different types of anomalies that you're going to learn about, where the teeth naturally just have spaces in between them. Again, it's going to be annoying to the patients. There are things that we can do to try to change that, but it will require either the use of crowns or veneers to be placed on the teeth, something cosmetic to prevent the open contacts that are present. If an open contact does exist when a filling is placed in, then it will require the dentist to have to redo it. So want to make sure that what we take off is put back in. So these black lines here are showing the contact areas of each of the teeth. The other type of anatomical feature is the embrasures, and the embrasures are basically the triangular space near the gingiva, and it's going to be located between the proximal surfaces of two adjoining teeth. They are continuous with the interproximal space between the teeth, and they're going to contour, is going to include the contact area as well. And we have here, again, this triangular space here. This is showing, the blue dot is showing the gingival embrasures. And again, we have posterior and anterior. And it's also showing you the occlusal embrasures. So it's creating that triangular shape is what the embrasures are. And again, that's just to protect and prevent any kind of trauma or irritation to the tissue. So again, when we're putting a filling back in, we want to make sure that we have the proper contour and that we're just not keeping this kind of straight like a box would be, because then that's not going to allow for the protection that it's going to need. Not only that, the patient's not going to be able to bite properly because we want to make sure that we are contouring the tooth so that when you bite together, that it's going to occlude correctly. We can also see the embrasures, not just if we're looking at it from a lingual, facial, or buccal aspect, but if we're looking at it from the occlusal, to see those embrasures here as well. Again, those triangular shapes that creates when you have two teeth kind of coming together. Height of contour is kind of the same concept. Each tooth has these bulges on the teeth that, again, is there to protect. Our teeth are designed very strategically to allow food to be there when it's supposed to, and when it's not, to kind of move it away to protect the tissue. So our anterior and posterior teeth have these bulges or height of contour, and it's where that bulge is going to be the most prominent in the area. This is looking at the teeth from a proximal view, or as if we're looking at it from either the mesial or distal, so that we get a better understanding of where those height of contours are going to be on the facial and lingual surfaces or on the buccal and lingual surface. Coming back to this picture here, the height of contour, if we're looking interproximally, is always going to be where that contact is going to take place. So here on the anterior teeth, we can see that the height of contour is going to take place a little bit more towards the incisal edge. And then as we get a little bit more towards the posterior back here, that height of contour for both of these teeth where they touch and come in contact with each other to create that contact point is going to be more towards the middle of the crown of the tooth there. Line angles and point angles, this can always be very confusing. Basically with line angles, it's where two surfaces come together. So that could either be a mesial, buccal, distal, lingual type of a thing, or it could also include the occlusal surfaces as well. So the way I like to kind of demonstrate this is to think of a box. Okay, bringing out the analogy of the box just like we did with the surfaces. Here's the mesial surface, distal surface, buccal surface, lingual surface. So if this is buccal, then we're looking at a posterior tooth here. But this applies for if this were even a facial here. So where two surfaces come together, for example, this here, these two are coming together. Here's the mesial, here's the lingual. That would be considered the mesiolingual line angle. And again, we're using abbreviations. Coming to this one here, this is the mesial that's touching the buccal. That's going to be the mesial-buccal line angle. This one, you have the distal touching the buccal. So that's going to be which one? If you said distal buccal line angle, that is correct. And then lastly here, we have these two surfaces, distal and lingual, coming together. That would be considered your distal lingual line angle. And just as you have for these surfaces here, if you were to have even two surfaces, you could have a mesial occlusal line angle, which would be more here. So this is the distal surface, this is the occlusal surface. So where the two come together and meet would be considered your distal occlusal line angle. Same here, linguo-occlusal line angle here. This is your mesio-occlusal line angle. And then this one would be either your bucco-occlusal line angle, or if this were an anterior tooth, your facial incisal line angle here. So just as you have here on the sides, you can have here at the top as well. So it's where two surfaces meet and come together is considered a line angle. Point angles are going to be where three surfaces come together. So that's now going to be, if we think of the box, now it's taped and closed together. Here's buccal facial. This up here would be either occlusal or incisal, distal, lingual, mesial. So this is where three surfaces are coming together. So three surfaces, you have your mesial, your lingual, and your occlusal. So the way to think of it, if you were to look at a wall or a room, it's the point the corner of the room where you have two walls and the ceiling come together. That is basically considered your point angle. So again, if this were occlusal or if this were incisal, it would be either MLI or MLO point angle. This one, mesial, buccal, or facial, and incisal or occlusal. So it's your MFI or mesial, buccal, occlusal point angle. Three surfaces coming together. Here's your distal, your lingual, and your occlusal or incisal, which creates that point angle. And then here you have your distal surface, your buccal or facial surface, your occlusal or incisal surface to create that point there, which is your point angle. So hopefully that helps to explain the difference between what a line angle is, which is two surfaces coming together, versus a point angle, which is now three surfaces coming together. Division into thirds, and this is actually in your packet here. So make sure you kind of get your packet out and make sure you fill in the blanks here as we go through this. Division of thirds is the way to identify specific areas of the tooth. We're dividing it based on the crown and also with the root. So if this is an anterior tooth here, you can't really see, I'm kind of pointing here. Here, this third up here between these two here, because this is the apex of the tooth, would be considered our, let me see if it'll let me write here, our apical third. And it's hard to try to write with the mouse. So apical, and that's an L. Let me move that out of the way, see if I can. Much better, okay. Apical third. So it should be here in between this area here. This would be considered our apical third. It's A-P-I-C-A-L, apical third. This one here, because it's in between, would be our middle third. And I'm just going to put a 3. Middle third. This one, because it's towards the cervix or the neck of the tooth, would be considered our cervical third. And from here on out, I'll just use the abbreviations. So this takes care of the root portion of this anterior tooth. Now we're coming back down the crown, and we have, yep, this would be our cervical third. So I'm just going to put a C3. It basically is this one up here, cervical third. Same thing. This is in between, right here. So this would be our middle third. So I'm going to do an M3 for middle third. And then because this is an anterior tooth right here, this area right here would be considered our incisal third. So I'm just going to put an I, incisal third. So this is doing it horizontally. Now we're going to focus on vertical. Now we're doing our surfaces. We're going to say this is towards the midline. This is away from the midline, this surface here. So this one would be our mesial third. I'm going to do an ME because I abbreviated just an M for middle. So mesial third. this line should actually extend downward. So this middle section here would be the middle third. Not supposed to be M for middle. And then if this was the mesial here, then this is going to be the distal third. So that's looking at it from the facial view. Now this is looking at it from the interproximal. We've turned this on its side. We know based on how the tooth is contoured, this is the facial, this is the lingual. So just like we did here, this third of the tooth of the crown would be the facial third. This is in between, so it is the middle third. And this is opposite facial, so this would be the lingual third. So that's what the anterior dividing into thirds looks like. So when we go back, let me see if it'll let me go back here. Now, let me finish this and let me see if I can go back to kind of show you why we divide into thirds. So now focusing on the posterior tooth, this is as if we're looking at it from, again, the buccal view here. So we're looking at it straight on. Let's start with down here. This should be easy for you to get. This would be our cervical third here, because it's towards the neck of the tooth or the cervix of the tooth. The middle third, and our apical third. We know this top portion right here is a chewing surface of the tooth, so that would be, our occlusal third. Then we have our middle third of the crown, and our cervical third. And this is now dividing by surfaces. So if this is, like I mentioned, towards the midline here, this is away from the midline, then we know this one would be the mesial third. I'm going to do ME for mesial third. This is our middle third. And then our distal third. And this one, this is as if we're looking at it from, again, interproximally. So we turn the tooth on its side. Now we're looking at, again, this is towards the cheek side, this is towards the tongue side. So towards the cheek side on the posterior is buccal third, middle third, and lingual third. So make sure you have that in there. So let me see if it'll let me go back here. So here, when we were talking about the height of contour and the contacts with the teeth, we can now say that the contact point for this central and this lateral is more towards the incisal third. Here, it's more towards the middle third. This one between these two is going to be more towards the And this is going to be different because you have, this is a posterior tooth, this is an anterior tooth. So we can say that for this tooth here, because it's an anterior tooth, it would be more on the third of the tooth, whereas this one, it's a posterior tooth, it would be more on the occlusal surface of the tooth. Here, these two posterior teeth, that point of contact where they touch would be more along the middle third. So as we're identifying different pathologies or issues or concerns going on with the tooth, we can now break it into further with its the fracture is along it's more so along the incisal third of the tooth, or it involves the middle third into the incisal portion of the tooth. Now focusing on occlusion. Occlusion, we have what's considered an overbite and an overjet. And just to kind of give you some information regarding occlusion, occlusion is what happens when the maxillary and the mandibular teeth come together. So when we tell the patient to bite together, they are occluding. So when the maxillary teeth touch the mandibular teeth, we call that occlusion. So we always want to check the bite. Occlusion is also known as the bite, to ensure that there is no issues or problems, especially if we have restored a tooth, we've put a filling in a tooth, or we've done a crown on a tooth. We want to make sure that when the patient bites together, that all of their teeth are coming together like it's supposed to. Because if not, that's going to create some issues down the road that can lead to some bigger problems over time. So we have two concepts with occlusion. We have what's considered to be an overbite. You might have heard this term being used. And an overbite is determining the vertical aspect. So how far down do your maxillary centrals overlap your mandibular centrals? That's considered an overbite. You want to be able to see a little bit of the mandibular centrals in order for it to be considered more normal. A person who has a deep overbite, you cannot really see those mandibular centrals at all because the maxillary centrals are covering it completely. The overjet is referring to the horizontal space. So how much space is in between from the facial of the mandibular centrals in conjunction or relation to the lingual surfaces of the maxillary centrals. So that would be considered your overjet. So overbite is how much it overlaps the mandibular centrals, and overjet is the space between the facial of mandibular in relationship to the lingual of the maxillary central. I've had braces before. I had braces when I was younger, never wore my retainer. When I got older, I decided to do braces again. Like I mentioned, I had a tooth extracted, so I wanted to make sure everything was, there was no space there. So when they did my braces a second time, I have a slight overjet where the space between that opening between my maxillary centrals and mandibular centrals is a little bit bigger. So I have a really hard time if there's anything that involves lettuce, for example, it just kind of goes through. So I have a hard time I have to kind of move it to the side to try to make sure that I get it kind of broken up, because it's just going to slide through because of my overjet. In asking my dentist when I worked for him if I should consider getting braces again, he had me open my mouth and swallow, and he said it's not going to do anything because I have a slight thrushing of the tongue. So when I swallow, my tongue comes forward a little bit, and that basically is kind of creating that overjet that I have. It's going to take, by this time that's just how I swallow. That's what I what I do is my tongue juts forward. So there's no correcting that, unfortunately. So even if I were to get braces over time, that opening or that overjet will be open up again for that reason, because of the tongue thrust that I have, just as, you know, something I do. So people that suck their thumbs or have a pacifier, it tends to create a little bit more of an overjet, where these anterior teeth here tend to thrust more forward. As a result of it starts to contour to either their thumb, or if they're constantly using a pacifier, it starts to contour to that, which is then pushing those anterior maxillary teeth out a little bit further than what they're supposed to be. So if you do have children in your office that are coming in like that, then we need to be talking with the parents to see, well, what are they doing? What habits do they have? Or it could be that they have a tongue thrust when they swallow or speak, where that tongue kind of juts forward. There are some things that we can do to correct for kiddos that suck on their thumb, and possibly some things we can do to try to correct the overjet as well, or if they are tongue thrusting, especially early on, and not waiting until they're older like me to try to get rid of that habit. So again, that's kind of showing you what that looks like. The teeth tend to start to contour to the thumb. And this kind of shows you what that overjet kind of looks like. You can see where those anterior teeth are really kind of jutted more forward. We have something called centric occlusion and functional occlusion. Centric occlusion occurs when the jaws are closed in a position that produces maximal stable contact between the occluding surfaces. So basically our centric occlusion is what we consider to be a normal occlusion. When we bite together, it's going to be centric occlusion. So when you, if you were to ask you to bite together, close your mouth, bite together, that's going to be your centric occlusion. So how your maxillary and mandibular arches come together and how your teeth connect is your centric occlusion. Functional occlusion is what occurs when we're chewing, because we're not chewing in an up and down motion because our mandible is movable. We are kind of rotating it a little bit to make sure that the food that we're putting into our mouth is getting crushed and getting broken up into tinier pieces, so that when we swallow, it's not getting stuck in our esophagus and it's easier in our digestive system. So just know the difference between centric and functional occlusion. We also have what's known as Engel's classification. Mr. Edward Engel in 1890 developed this Engel's classification system that basically determines normal from abnormal. And there's 3 different types of malocclusion. Malocclusion, again, occlusion is bite. Mal or mel is from your med terms, is bad. So we're talking about bad occlusion. So a class 1 is what we would consider to be normal. And it has to do with where the maxillary first molar cusp comes in contact with the mandibular groove of the mandibular first molar. So this would be what we would consider to be normal occlusion or neutral occlusion, a class 1. We can have a class 1 where our the guides that we use to determine a normal occlusion are there, but there could be some crowding occurring in the anterior region. So we would still consider it a class 1 occlusion with some crowding occurring, and we would determine where that crowding is. Class 2 is known as a distal occlusion, and again, it's where they line up is what you're wanting to look at, and you can see that the maxillary is going to be more towards, it's going to be more retruded or more forward in conjunction with the mandible. And there's going to be different types of class 2 malocclusion that your book kind of talks about, and it does depend on how far forward these anterior teeth are going to be protruding in relationship to those mandibular centrals. And then we have our class 3, which is known as mesial occlusion. And again, just noting where that maxillary first molar cusp is now where it's lined up. And we can now see that the mandible is more mesial, or it's more forward in comparison to the maxillary arch. So these are the 3 types of classifications that we would classify a patient into once we're doing the exam and looking to see how they occlude. So this is also in your handout that I handed out last week, so make sure you get this filled out. And this is what we're looking at here, is that relationship between that cusp is fitting nicely into that groove of that mandibular first molar. This is our class 1. Let me see if I can get my other pen here. So this is a class 1, also known as, and you can look in the book, it'll tell you, it's also known as neutro occlusion. Neutro meaning it's neutral, so where it occludes is what we want to see. This one here is showing you class 2, and I'm not going to write class, I'm just going to put 2, but make sure you identify it as class 2. And this is known as retrognathic. So if you think of retro as back in the day, the mandible in comparison to the anterior or to the maxillary is more retruded backwards. So it's more towards the back. And this would be your division 1 here and your division 2. So even though where that cusp lines up is the same, it's how much and how much crowding is occurring and how much retruded those anterior teeth are in comparison is going to be whether it's a class 2 division 1 occlusion or a class 2 division 2 occlusion. And then this one down here is going to be your class 3. And we always use Roman numerals usually when we're identifying classifications of things unless specified. So class 3. And this is known as prognathic. This was retrognathic. This is prognathic, meaning pro forward. So the mandible is protruded more forward in relationship to the maxillary. This class 3 almost gives like a bulldog appearance. So we want to make sure again that when we refer a patient to ortho, that they're getting this treated, because this can cause a lot of, especially TMJ issues, because of the way the mandible sits in relationship to where it should in the joint. This here shows you what the profile looks like for a person who has a class 1 occlusion, which is pretty normal. Class 2, you kind of see where maybe that mandible looks like it's not fully formed in conjunction or relationship to the maxillary. The maxillary is almost retruded outward. And then this one's kind of the opposite, where it's now the mandible that's more retruding or protruding outward in comparison to the maxillary arch. So make sure you have an understanding of Engel's classification of occlusion. Let me exit here. Also overbite and overjet, and being able to identify what is what. We have, again, something that's known as the curve of Spee. This just helps to determine, again, when we're looking at it from the buccal surface or the cheek side of the teeth, that we want to see that curvature. This would be an example of what concave looks like. Let me see if I can get my pointer here. So the shape that it creates or makes, again, our teeth are not straight all the way back. There is that little bit of a concavity to it, or a concave to it, where it kind of creates that almost like a bowl appearance. And it's purposely designed that way. And this is going to come in handy, especially when you're mounting x-rays, is to look for that curve of SPE. You always want to look for that smile line when you get to the posterior teeth. We always say that if you have a frown, it's upside down. So you want to look for that smile. This is an example of looking at that curve of SPE and seeing that nice, how it kind of goes from here and then it kind of starts to raise up as we get more towards the posterior to create that concavity here as the teeth are occluded. And you can see the difference between this one, which is correct, and this one, which is incorrect, because you see that it's frowning. We always want to make sure that that curve of SPE has the smile and not the frown. And then lastly, curve of Wilson is now looking at it from posterior of the right side to posterior of the left side. And that curve of SPE, again, helps us when we are trying to determine the functionality of our occlusion. Because when we put a filling back in, we want to ensure that we're trying to match the anatomy as best as we can, so that when we are chewing, that where the cusps are aligned are going to be hitting in the right areas. We don't want one side to be higher than the other, because then that's going to create a lot of issues with the TMJ. So we want to make sure that it's going to be as even as possible. So this is going to come in, especially when we're making partials and dentures, to make sure that not only do we have the curve of SPE, that smile concavity to it, but also that we have the curve of SPE from right side to left side on the posterior teeth, to ensure the patient is going to be occluding properly so it doesn't create any issues or problems long term. So please look over your chapter, read the rest of what we went over today to kind of get a better sense. This was meant to be more of an overview, so you will need to also read a little bit, take some notes if you need to, replay this video if you need to jot down some notes or highlight your book. Please go back in and complete those 2 activities that were left of your packet, because this is going to be a really good study tool for you for upcoming exams and also for your final exam as well. Reach out if you have questions and complete your activities for the week.